Namaste JVN. Myself, JVN Dr. Ravi Jain, Associate Professor and HOD, Department of Practice of Medicine, in Faculty of Homeopathic Science at JYOTI VIDYAPEETH Women's University, Jaipur. In this series of lectures, on 25th of May 2024, we will be discussing about the complication of diabetes mellitus. We will be discussing about the late complication of diabetes mellitus. In this lecture, we will be discussing about diabetic retinopathy. In the next two lectures, we will be discussing about diabetic nephropathy and neuropathy respectively. So let us start with the complications of diabetes mellitus. Diabetes complication. The diabetes-related complications affect many organs, systems, and are responsible for the majority of morbidity and mortality that is associated with the disease. Diabetes is a leading cause of new blindness in adults, renal failure, and non-traumatic lower extremity amputation. Diabetes-related complications can be divided into vascular and non-vascular complications. So the diabetes-related complications, this may affect many organ systems and is responsible for majority of morbidity and mortality that is associated with the disease. Diabetes is a leading cause of new blindness in adults and renal failure and a non-traumatic lower extremity amputation. Diabetes-related complications can be divided into vascular and non-vascular complications. Vascular, that is related to the blood vessels, and non-vascular, not related to the blood vessels. The vascular complications of the diabetes mellitus are further divided into microvascular, that includes the retinopathy, neuropathy, and nephropathy that we are going to discuss in today's three lectures. Macrovascular complications that includes the coronary heart disease, peripheral arterial disease, and cerebrovascular disease. Non-vascular complications includes gastroparesis, infections, skin changes, and hearing losses. So the vascular are divided into two, microvascular and macrovascular. In microvascular, we have diabetic retinopathy, nephropathy, and neuropathy. In the macrovascular complications, we have coronary heart disease, peripheral arterial disease, and cerebrovascular disease. In non-vascular complications, we have gastroparesis, infection, skin changes, and hearing losses. In the diabetes-related complication, microvascular, we have eye diseases, that is known as diabetic retinopathy. It can again be divided into two parts, non-proliferative and proliferative. We can have macular edema. Neuropathy, that includes sensory and motor, which includes mono or polyneuropathy or autonomic neuropathy. Third is the nephropathy, that includes albuminuria and declined renal functions. Macrovascular complications includes the coronary heart disease, peripheral arterial disease, and the cerebrovascular disease. So in microvascular, we have eye, kidneys, and nephron and neurons. In the eye disease, we have retinopathy and macular edema. In the neuropathy, we have sensory and motor neuropathy and autonomic neuropathy. And in nephropathy, we have albuminuria and declined renal function. And in the macrovascular disease, we have coronary heart disease, peripheral arterial disease, and cerebrovascular diseases. Next, we have the other complications of which includes gastrointestinal, that is gastroparesis and diarrhea. We have genitourinary, that includes uropathy, sexual dysfunction. We have dermatological, which includes infection, cataract, glaucoma, chorioarthropathy, which includes thickened skin and reduced joint mobility, and periodontal disease, and hearing loss. So the other complication, diabetes-related complications include gastrointestinal complications like gastroparesis and diarrhea, genitourinary, which includes the uropathy, sexual dysfunction, dermatological manifestations, infections, cataract, glaucoma, chorioarthropathy, that is thickened skin and reduced joint mobility, periodontal disease, and hearing loss. The mechanism of complications. Chronic hyperglycemia is an important ecological factor leading to the complications. 4 theories on how hyperglycemia can lead to chronic complications of diabetes mellitus includes: number 1, increased cellular glucose leads to the formation of advanced glycosylation end products. which binds to the cell surface receptors via the non-enzymatic glycosylation of intra and extracellular proteins, leading to the cross-linkage of proteins, accelerated atherosclerosis, glomerular dysfunction, endothelial dysfunction, and altered extracellular matrix composition. Hyperglycemia increases glucose metabolism via the sorbitol pathway related to enzyme aldose reductase. Hyperglycemia increases the formation of dicycloglycerol, leading to activation of the protein kinase C, which alters the transcription of genes for fibronectin, type 4 collagen, contractile proteins, and extracellular matrix proteins in endothelial cells and neurons. The fourth point includes hyperglycemia, increases the flux through the hexosamine pathways, which generates fructose 6-phosphate, a substrate for O-linked glycosylation and proteoglycan production, leading to the altered function by glycosylation of proteins such as endothelial nitric oxide synthetase, or by changes in gene expression of transforming growth factors or plasminogen activator inhibitor. There are various ophthalmological complications. Diabetes mellitus is the leading cause of blindness between the age group of 20 to 74 years of age. Severe vision loss is primarily the result of progressive diabetic retinopathy and clinically significant macular edema. Diabetic retinopathy is classified into two stages, non-proliferative and proliferative. So in diabetic retinopathy, we have two types, non-proliferative and proliferative. The clinical features of diabetic retinopathy includes microaneurysm, retinal hemorrhages, that can be of dot hemorrhage or clot hemorrhage, exudates, the cotton wool spots, venous changes, neovascularization of that is the retina and the iris, preretinal subhyoid hemorrhages, vitreous hemorrhages, and fibrosis by gliosis. So the clinical features include the microaneurysm, retinal hemorrhages, dot and blot, exudates, cotton wool spots, venous changes, neovascularization, that is retina and the iris, preretinal subhyoid hemorrhages, vitreous hemorrhages, fibrosis by gliosis. The non-proliferative diabetic retinopathy appears late in the first decade or early in the second decade of the disease. This is marked by retinal vascular microaneurysm, blot hemorrhages, and cotton wool spots. So the non-proliferative diabetic retinopathy is occurring in the first decade or the early second decade of the disease condition. It is marked by the retinal vascular microaneurysm, blot hemorrhages, and cotton wool spots. Mild non-proliferative retinopathy may progress to more extensive disease characterized by changes in the venous vessel caliber, infraretinal microvascular abnormalities, more numerous microaneurysm, and hemorrhages. So there is mild non-proliferative retinopathy that may progress into more extensive disease condition that is characterized by changes in the venous vessel caliber, intraretinal microvascular abnormalities, and more numerous microaneurysm and hemorrhages. The pathophysiological mechanism in non-proliferative retinopathy includes loss of retinal pericytes, increased retinal vascular permeability, alterations in the retinal blood flow, abnormal retinal microvasculature, and all of these leading to retinal ischemia. So the pathophysiological mechanism in non-proliferative retinopathy includes loss of retinal pericytes, increased retinal vascular permeability, alteration in the retinal blood flow, abnormal retinal microvasculature, and all of these leading to retinal ischemia. Proliferative diabetic retinopathy is characterized by appearance of neovascularization in response to retinal hypoxemia. Newly formed vessels appear near the optic nerve or macula and rupture easily, leading to vitreous hemorrhages, fibrosis, and ultimately retinal detachment. All the individuals with non-proliferative retinopathy do not go on developing proliferative retinopathy. But more severe the non-proliferative disease, the greater is the chance for evolution to proliferative retinopathy within 5 years. So all the individuals with non-proliferative retinopathy do not progress to proliferative retinopathy, but more severe the non-proliferative disease, the more is the chance for evolution into proliferative retinopathy within 5 years. This is the diagrammatic representation of the diabetic eye disease. A showing the background diabetic retinopathy, showing microaneurysm and blot hemorrhages. We have blot hemorrhages when we have microaneurysm. In the B, background shows exudates. We can see the exudates. C, maculopathy showing edema. This is the edema. D, again exudates. Maculopathy with exudates. E, we have pre-proliferative retinopathy showing venous changes in cotton wool spots. This is the cotton wool spots. And F, with neovascularization, new blood vessel formation taking place. Macular edema can occur in context of non-proliferative or proliferative retinopathy. Fluorescein angiography and optical coherence tomography are useful to detect the macular edema. So macular edema can be detected by fluorescein angiography and optical coherence tomography. Duration of diabetes mellitus and degree of the glycemic control are the best predictors of development of retinopathy, hypertension, and nephropathy. So the degree, the duration of the diabetes mellitus and the degree of glycemic control, these are best predictors for the development of retinopathy, hypertension, and nephropathy. Now, what are the various investigations that can be done in case of diabetic retinopathy? The preferred method of is the digital photographic system for retinal imaging. We can go for digital photographic system for retinal imaging. Prompt referral of the patients with slight sight-threatening retinopathy to an ophthalmologist. Examination with slit lamp biomicroscopy. If direct ophthalmoscopy is used, the pupils should be dilated for adequate examination. So in the investigation, preferred method is the digital photographic system for retinal imaging, prompt referral of patients with sight-threatening retinopathy to an ophthalmologist, examination with slit lamp biochemistry, and if the direct ophthalmoscopy is used, the pupils should be dilated for adequate examination. The treatment of diabetic retinopathy, most effective therapy for diabetic retinopathy is prevention. The intensive glycemic and blood pressure control. The regular treatment includes the comprehensive eye examination are essential. Laser photocoagulation is very successful in preserving vision. So the treatment of diabetic retinopathy includes most effective therapy for diabetic retinopathy is preventive. The intensive glycemic and blood pressure control. Regular comprehensive eye examinations are essential, and laser photocoagulation is very successful in preserving the vision. The proliferative retinopathy is treated with pen-retinal laser photocoagulation. So the proliferative retinopathy can be treated with pen-retinal laser photocoagulation. The macular edema is treated with focal laser photocoagulation and antivascular endothelial growth factor therapy. So proliferative retinopathy, this is treated with pen-retinal laser photocoagulation. Macular edema is treated with focal laser photocoagulation and antivascular endothelial growth factor therapy. So this was all about the diabetic retinopathy. Let us again revise this diabetic retinopathy. Ophthalmological complication, that is diabetic retinopathy. It is the leading cause for blindness between the age group of 20 to 74 years. And there is severe vision loss that is primarily resulting from the progressive diabetic retinopathy and clinically significant macular edema. Diabetic retinopathy is classified into two parts, proliferative and non-proliferative type. The clinical features includes the microaneurysm, the retinal hemorrhages, which includes dot and blot hemorrhages, exudates, cotton wool spots, venous changes, neovascularization of retina and the iris, preretinal and subhyoid hemorrhages, vitreous hemorrhages, fibrosis and pleosis. The non-proliferative diabetic retinopathy appears late in the first decade and early in the second decade of the disease. It is marked by retinal vascular microaneurysm, blot hemorrhages, and cotton wool spots. Mild non-proliferative retinopathy may progress into more extensive disease that is characterized by changes in the venous vessel caliber, intraretinal microvascular abnormalities, and more numerous microaneurysm and hemorrhages. The pathophysiological mechanism in non-proliferative retinopathy includes loss of retinal parasites, increased retinal vascular permeability, alteration of the retinal blood flow, abnormal retinal microvasculature, and all of these leading to retinal ischemia. Proliferative diabetic retinopathy is characterized by appearance of neovascularization in response to the retinal hypoxemia. The newly formed blood vessels appears near the optic nerve or the macula and rupture easily, leading to vitreous hemorrhages, fibrosis, and ultimately retinal detachment. All individuals with non-proliferative retinopathy do not go to develop proliferative retinopathy, but more severe the non-proliferative disease, the greater is the chance for evolution of proliferative retinopathy. These are the changes we have seen in the diabetic retinopathy, macular edema, fluorescein angiography, and optical coherence tomography is done. The investigation includes a prompt referral to the site-threatening retinopathy to an ophthalmologist, examination by slit lamp biochemistry, and direct ophthalmoscopy. Treatment. The most effective therapy for diabetic retinopathy is preventive. Intense glycemic and blood pressure control, regular comprehensive eye examination, and laser photocoagulation is very successful. Proliferative retinopathy is treated by panretinal laser photocoagulation, and macular edema is treated by focal laser photocoagulation and antivascular endothelial growth factor. So this was all about diabetic retinopathy. I hope you must have understood the session properly. In the next lecture, we are going to discuss about other complications like diabetic neuropathy and diabetic nephropathy. So this was all for today. Thank you very much. Have a good day.